Welcome to Health Management Academy. In part 3 of the Resource Management Operations video, we'll be discussing the process for an efficient and effective Utilization Review Committee.
The Utilization Review Committee establishes procedures for the review of medical necessity of admission, the appropriateness of the setting, medical necessity of extended stays, and the medical necessity of professional services. Medicare Conditions of Participation, Section 482.3, requires any acute care hospital to have a utilization review plan and a utilization review committee. Members of the committee include 2 or more physicians. One must include the physician advisor. Other members may include the Chief Nursing Officer, Chief Financial Officer, Director of Resource Management, and other ancillary department representation that is deemed important to effective outcomes. It is important to remember the committee reviews cannot be conducted by any physician who has a direct financial interest to the institution or that is professionally involved in the care of the patient whose case is being reviewed. While most facilities have a dedicated utilization review committee, opportunity remains present for streamlining efficiency and effectiveness that will result in positive clinical and financial outcomes. Now let us see an example of a UR committee meeting.
Good morning, I'm Dr. Schroeder, and I'd like to call the Sparks Utilization Review Committee meeting to order. As usual, this meeting will be conducted with Robert's Rules of Order. Please refer to the agenda for order of subjects that will be discussed today. Ms. Watts has provided each of you with a copy of the minutes from last quarter's Utilization Review Committee meeting. Are there any additions, deletions, or amendments? Hearing no nays, do I hear a motion to approve the minutes as they stand?
I make a motion.
Dr. Rogers has made a motion to approve the minutes from the third quarter 2009 Utilization Review meeting. Do I hear a second?
A second.
Dr. Campbell has seconded. All in favor? Aye.
Aye.
Minutes stand approved. Let's review the old business. During our last meeting, we referred Dr. Dooley to the Medical Executive Committee because of length of stay. Do we have any follow-up from the MEC?
Yes, the information on Dr. Dooley was presented to MedExec, and MedExec has requested that we provide comparison with his peer group prior to taking any actions. So I make a motion that we provide to the peer group comparison to MedExec with these following categories: the peer group length of stay overall, the peer group length of stay by payer, and peer group by DRG.
Any questions or amendments to the motion?
Second.
All in favor? Aye.
Aye.
All opposed? Hearing none, motion carried. The next item for follow-up is our trend in delayed MRI testing that was leading to denials.
After our data analysis, we discussed with our administrative team that having MRI testing available only 3 days a week was negatively impacting our length of stay, and it was increasing our managed care denials. So we worked with our radiology department and their director, and she conducted a cost-benefit analysis, and we were able to justify that having MRI coverage 5 days a week would really help prevent these things. You've got in your packets, if you'll open those up, review those, you'll find our data analysis, and the information in this packet is going to be provided by our radiology director at our next MEC meeting, so we can get that endorsed.
Are there any questions to the cost-benefit analysis or recommendations? Hearing none, can we have a motion to approve the analysis?
A motion to approve.
Second.
Any opposed? Hearing none, let's move on to new business.
Action and follow-up from previous meetings is an essential element that should be reflected in your Utilization Review Committee's minutes. While our goal is to consistently improve, a portion of our responsibility as a UR committee is to ensure accountability for planned actions based on the identified trends. These actions demonstrate to the Joint Commission surveyors and CMS surveyors that you have a process in place for the identification of deviations from the norm, action planning and execution of the plan, and follow-up to appropriately impact over/under utilization of hospital services.
I understand each of you has received a draft of the proposed utilization review plan for 2010. This plan must be updated and approved annually by the UR Committee, MEC, and governing body. Any comments or concerns related to the proposed plan? Not hearing any concerns or comments, do I have a motion for the approval of the plan?
Motion to approve.
Second.
Dr. Rogers has made a motion to approve with Dr. Campbell as second. It has been moved and seconded that we approve the 2010 UR plan. All in favor vote aye, and those opposed vote nay. Aye.
Aye.
The ayes have it, and the 2010 UR plan is approved. Ms. Watts, please provide us with assessment and overview of the utilization program for Sparks Health System for the second quarter 2010.
Appropriate and accurate level of care assignment should be addressed prospectively, concurrently, retrospectively, and through identified patterns and trends. Prospective review is defined as explicit and implicit review through the ER observation process. Concurrent review is explicit and implicit review during the hospital stay as per facility UR plan. This is inclusive of 1- and 2-day stays. Retrospective review includes explicit and implicit review on identified cases with appropriate intervention as per facility UR plan, compliance work plan, or other UR committee-directed reviews. This is inclusive of 1- and 2-day stays. For patterns and trends, identified trends will be compiled and trended by attending physician, ER physician, time of placement, or other category as required. UR committee conclusions will be sent to the MEC and governing board at each facility for appropriate medical staff intervention and follow-up.
Well, for the second quarter of 2010, you can see here we had a total of 37 OBS, and of those observations, 34 came from our ER. And those were the 34 that we had an explicit and implicit review. The following 3 FINs here that you see, we were not able to get that review completed, and those are going to be presented to you today for review by the committee. Resource Management did do a preliminary review, and we found preliminarily on these that a prospective review was not completed and the process was broken in the ED. We did, however, provide education to our emergency department and the resource management staff on June 12th, and hopefully we can prevent this kind of variance in the future. And we're going to continue to assess for outcomes, and we'll bring those outcomes to this committee. For April, our denials, we had 1. May, you can see we had 2. And in June, we also had 2. One of the trends we found was with Blue Cross Blue Shield, and 3 out of the 5 cases, again, were trended from our ER. When you look up here on our Pepper report, we noticed that our readmission rate with our MI, CHF, and pneumonia for the second quarter was 12%, and this puts us below the national average. And on June 30th, we conducted a community resource management work group, and we discussed and identified these trends. We've got a subgroup from that working on a standardized communication tool between the hospital and the home health. And hopefully, as soon as that's complete, we can bring that back to this committee, and we can have you all review that for approval and implementation. Down at the bottom here, you'll see our potentially avoidable days. We had 15 for the quarter, and most of those we noticed were related to the MRI delays. This is a holdover from our previous discussion regarding our old business, and we hope to have a resolution for this in the upcoming quarter.
Thanks, Ms. Watts, for the assessment and overview. Let's proceed to the medical record review. Committee agrees 2 of the 3 records, the implicit documentation supported inpatient status, and 1 of 3 of the documentation supported explicit and implicit screening for the observation services. Recommendations include referring the 2 missed admissions to Medical Executive Committee and Governing Board for review. Do I have a motion?
A motion.
A second?
Second.
Motion approved and seconded. Follow-up to be provided at the third quarter 2010 UR Committee meeting regarding MEC and Governing Board recommendations and actions. Is there any other new business?
Yes, Dr. Schroeder, I have one. I'd like to review, at our last meeting, we briefly discussed how we would be developing processes to identify high-cost services and use an evidence-based approach to reduce the usage of the services. We've been able to formalize that process, and I'm now presenting it to you for review and approval. This is our first resource trigger. It's looking at the usage of inpatient MRIs. We've provided you with literature to support our process, and we've outlined that process. The process is going to include the review of the test by a radiologist. Then he shall discuss that with the attending before performing the test if appropriate standards are not met. Should there be disagreement between the 2 physicians, then the physician advisor would be involved just like our other UR processes. We will be monitoring the outcomes, and with this trigger, we're going to report the results to this committee along with our other metrics. Do you all have any questions or comments regarding this?
Not hearing any questions, do I have a motion to approve?
A motion to approve.
Second.
Not hearing any opposed motion, approved. With no further business to report, I would entertain a motion to adjourn.
So move.
Do I have a second?
Second.
Motion approved and seconded. Meeting adjourned.
Efficiency is key to providing quality health care and to the financial success of any acute healthcare facility. With healthcare reform, it's more important now than ever to ensure that we are providing quality of care in the appropriate and accurate level of care and transitioning the patient throughout the healthcare arena in a timely and effective manner. Measurement of process and outcomes will continue to be a responsibility of the UR Committee, MEC, and Governing Board. Action and follow-up will be required for trends that impact patient care and utilization review. We hope this video has provided you with additional insight into an efficient and effective UR Committee.